maternal health. Our foreign policy should be based on American values and what we think about. And if we think about American values, 65% of women aged 15 to 49 use contraception methods. 99% of women who have been sexually active at some point have used contraception. Those are American values. And that's voluntary family planning. They're choosing to use those methods. We talk about being a faith-based nation. 98% of Catholic women have used modern contraception. 99% of Protestant women have used modern contraception. Those are American values. So we're talking about making voluntary family planning available around the world to reduce maternal mortality, to reduce child mortality. In developing countries, when you do proper pregnancy spacing, from 1 year to 2 years, you nearly have infant mortality rates. So we all should agree on making voluntary family planning available to women around the world. One of the most effective things, I'm glad that the ranking member talked about the things that we passed. PEPFAR, the Global Fragility Act, particularly focused on the youth bulge in sub-Saharan Africa, focused on fragile states in that region. The one thing that we actually could do to address the youth bulge is make voluntary family planning readily available to empower women. The Keeping Girls in School Act, the one thing we could do is to make sure there isn't that unintended pregnancy by making voluntary family planning available to those young girls. Women's Economic Empowerment Act. If we actually want to have impact for women around the world, we ought to put them in charge of their own reproductive health and allow them to do active pregnancy spacing. Dr. Cates, let me ask you a question. When you look at the impacts of the global gag rule, both in past years and through this administration's expansions, has it limited access to voluntary family planning?
So as has been mentioned, the U.S. policy supports voluntary family planning, and that is part of policy, and the U.S. provides funding, is the largest donor to that area in the world. But as I pointed out, the implementation of the policy has presented barriers, and there's been documented studies going into the field and talking to providers and looking at what has happened and doing surveys to say that they have faced barriers in being able to implement the programs that they are legally able to provide. They've lost partners, they've closed services. So it's not as simple as something is funded and the policy doesn't affect that. I think that's the complication here, and what is very hard to assess but is clearly being seen in the field. The study I mentioned from the Lancet is important to note because it looked back in different periods to try to say, is there a relationship between certain health outcomes, because ultimately that's what we're looking at, right, health outcomes, and the policy, and it found a pretty strong relationship. That definitely warrants further attention, because one of the challenges is if we can't immediately measure health impacts, we might not see the negative effects, if there are any, for years to come.
My impression is the way the administration's implemented the global gag, it has had this rebound effect, closing family planning clinics and et cetera, and limiting access. In the limited time I have left, Ms. Crocker, I had the chance to visit the Zaatari refugee camp in Jordan with CARE and visit the maternity clinic that UNFPA is running. It was a pretty amazing facility. There was State Department funding that helped start it, and of the 7,500 babies that were born at the time that I visited, there wasn't a single maternal death. Pretty impressive. That's what UNFPA can do. Is that clinic still running, and what is the impact of our not properly funding UNFPA?
Thank you for the question, and I'm so glad you had the chance to travel with us. The clinic, happily, is still operating, and now there have been 12,000 live births without a single maternal mortality at the Zaatari camp, over 12,000 live births. Until the U.S. stopped funding UNFPA in 2017, every bassinet in that camp displayed a U.S. flag. As of July 2019, UNFPA was facing about a $200 million gap in the over $500 million that it had asked for to date by that point. And so while some other donors have stepped in to try to help fill the gap that since the U.S. has stopped funding, there still is a very significant gap. What we can talk to is the incredible good work that UNFPA does around the world in over around 150 countries. And most particularly, I think, with a focus on what they do in humanitarian response, where they are sometimes the sole provider of quality reproductive and obstetric care, but they do even more than that. So in the ways in which CARE partners with them around the world, they do everything from providing clean birthing kits to training midwives to dealing with gender-based violence to dealing with prevention and treatment of sexually transmitted infections, as well as, again, the very important access to both family planning and reproductive health care in ways that are deeply needed in the context of humanitarian crisis and in certain circumstances where UNFPA is the only operator providing those services.
Well, so if we actually care about maternal health, if we care about child health, if we care about empowering women and girls, we ought to fund UNFPA.
Thank you. Mr. Chabot.
Thank you, Mr. Chairman. Ms. Boss, I'll begin with you if I can. Back